So welcome everybody. My name is Sohail Sood, a pediatrician at the University of California, San Francisco. And I'm sorry my lighting is not good this morning, so you're just seeing my silhouette. But we want to welcome all of you to the Global Child Health Lecture Series. Our last session was with one of the curriculum directors of the HEAL initiative, Dr. Robin Goldman, who presented a structural analysis of the patient in front of you. And that's I just mentioned that because I think it's a nice transition to the topic and the person, people with whom we'll be discussing continuing conversations with at this time, which is Dr. Emmy Connolly and one of her colleagues, Eneli Trinity Mhango, who will be presenting around policy to implementation of the Malawian emergency and critical care strategy. Maybe for the sake of time, Emmy, I will have you introduce yourself and your colleague a little bit further, if that works.
Yeah, that's great. Thank you so much, Sohail and Teresa and everyone who's part of the team. And thanks so much to everyone listening in. It's really exciting to have these lectures. I've been able to do them with different people a few years in a row, and it's just a lot of great feedback and discussion. So really look forward today. But as Sohail mentioned, my name's Emmy Connolly. I'm a pediatrician first, and then sort of moved into public health implementing, and then now have moved a little bit more over to the policy space and the connection between implementation and policy. And I work directly with the Ministry of Health in Malawi. I'm paid by Partners in Health and have worked with them for several years, but now working directly with the Department of Planning and Policy in Lilongwe, Malawi. And I'll let my colleague Eneli Mhango just introduce herself quickly before I give just a little bit more introduction. We're going to switch the talking kind of in the middle of the presentation, so you'll hear from her really soon. Go for it, Eneli.
Hi everyone, I'm Eneli Mhango. I'm a nurse by profession, and I'm working in the Ministry of Health in the Emergency and Critical Care Department. I'm the Emergency and Critical Care Technical Assistant. Just like Emmy, I'm paid by Partners in Health, but I'm full-time in the ministry, supporting their work. We call it accompaniment. So I'm so excited to be here and to share with everyone the work in progress, the policy implementation of the emergency and critical care strategy. Yeah, over to you, Emmy.
Great, thank you so much, Eneli. So I'll just start off with letting everyone know that Partners in Health has worked in Malawi now for 15 years. And we work mainly in what we call an implementing district in the Southeast. Perhaps some of you have heard of it. It's called Neno District. And that's where quite a bit of the direct implementation work occurs in accompaniment, as Eneli said, with the Ministry of Health on a local level. But over the past, especially 5 years or so, we've recognized the desire of the National Ministry of Health for additional technical assistance and basically just being able to work and help them sort of realize some of their strategies and goals. And the connection of creating a policy and making it actually implement and measuring it is an area that we've been asked to support in several departments. So we, both Eneli and I support in different departments, and then also in the non-communicable disease department, and then also in the monitoring and evaluation. So it's really helpful to have us there as a team also working together and being able to share information back and forth. So today we're going to talk to you mainly around the emergency and critical care strategy that's been developed over the past 2.5 years in Malawi and is now in the process of being implemented, which is being spearheaded by Eneli. We started back in 2019, and there was just not a lot of focus on emergency and critical care in Malawi. And one person that was able to recognize this quite clearly was Norman Lufisi, who is our leader and champion of emergency care and is a direct boss for Eneli, and really my boss as well in everything that I work for around this strategy. So he came up with this idea with his colleagues and sort of put it into motion. And so for about 1.5 years, we worked together in creating the strategy through a lot of consultations, evidence-based work, and bringing it into a strategy. And then over the past 9 months or so have been working to actually lead the implementation plan. So we're going to talk to you about that sort of cycle and how we've been working on that in the past 2.5 years. Let me there we go. So I think that I probably just did the introductions and background slide as well. So I'll just skip through this. But I just wanted to share with everyone sort of the cycle of policy development and iteration that I think is really helpful as we go through our presentation to be thinking about. And I think different people on the call may have different levels of experience in sort of the policy and implementation space. So we're just making sure that you all know sort of what we're saying when we're talking about it. But really, you could pick this cycle up as any cycle in any one of these spaces. But one really, I think for many of the policies is the start of actually creating the policy through taking the evidence that's there, consultations, expert opinions, especially in a place like emergency and critical care. You really need the specialists there and being able to set priorities, especially when you're in a low resource setting. 2 is really the implementation of the policy. There's a lot of advocacy, dissemination, planning, coordinating, really getting it going on the ground. And that's where we're at with the emergency and critical care, but also looking ahead to how do we monitor and test that implementation piece? Because without being able to understand where the challenges are coming from, perhaps there's parts of the policy that are not working well. We're not able to disseminate that information and advise to then create or recreate the policy to make it better. I think, unfortunately, a lot of places get stuck, right between like 3 and 4 and not being able to iterate back on the policy. And so sometimes, we get stuck with policies that perhaps work in a very beautiful way on paper, but aren't really being able to be implemented on the ground. So I'll just go through a little bit of the policy landscape just so you can understand where we're coming from in creating the emergency and critical care policy. And I think it's important also for how we're implementing it in the environments as well. I think probably many of you are aware of Malawi, but I know in less medical populations, sometimes people don't know exactly where it is, but it's right there in southeastern Africa, and it's known as the warm heart of Africa. There's about 19 million people estimated in this year, and about 65%, I think it's 68 specifically, of the population is children and youth under 21. So, one of those really big low end population curves. And about 80% or so live in very rural areas. Nano district, where Partners in Health works, is one of those. And it's near impossible for 3 or 4 months of the year to get to many of the primary care facilities due to the rains and mudslides and just inability to pass. So I think that's a real challenge in thinking about a policy, especially when you're talking about emergency and critical care. Another part on a national level, just to give you the background, is that Malawi is funded primarily in its health sector by donors. It's 58% as of 2021, and that's averaged about there or so for many years. However, all of that money ends up going to about 264 implementing partners. So not all of the donor money goes directly to the government. In fact, since around 2018, much of the money has not gone through the government from a scandal that happened. And so a lot of it goes directly to the implementing partners. And then unfortunately, sometimes that creates a misalignment where the partners are implementing strategies, interventions, policies that are not necessarily aligned to the government priorities. and can end up sort of looking like vertical systems where you're funding just HIV or TB or malaria, for example, which I'll talk about a little bit more. So just to sort of come off of this, I think probably many of you have seen this, but these are the Paris Declarations of Aid Coordination Principles. I think that it's just really important that for sort of alignment to policies and ensuring that everyone's able to implement the same things that are based on the prioritization from the government, there really needs to be that ownership from the government itself. And then all stakeholders, donors, different ministries need to be able to align to the objectives and use the local systems such as supply chain, equipment, procurement, et cetera. And then, of course, sort of avoid the duplication that can happen with many different implementing partners. Make sure that you're getting the results and evidence to show that what you're doing works. It sort of goes back to the cycle that I was talking about. And then finally, making sure that everyone is mutually accountable so that the government, holds up their side of it, but also the donors. I think that without the initial ownership and alignment, it's very difficult for the remainder of the principles. And so that's where also, the initiation and creation of this emergency and critical care strategy is really key for making this happen. So as part of a new shift in thinking, and I think because it's sort of gone really far to one direction, Malawi is really focused on taking a lot of the vertical disease platforms, as I mentioned, and you can see on the left part of the screen, to more integrating them at the different levels of care: primary, secondary, tertiary. In Malawi, there's just 3 levels at the moment, with plans, into the future to make a quaternary, 4th level, especially for specialty training. And right now, it really is critical to make sure, though, that a lot of these treatments and diseases are really integrated and decided on what interventions do we want at a primary level, and where can we build in efficiencies so that you can be using the same medications, the same equipment, the same diagnostics for all of the different diseases at a primary level. And so with making those sort of integrated systems, you can then do prevention and dialogue together with the communities. You're not having to do 6 different, campaigns for COVID vaccine, polio vaccine, and cholera vaccine, which we're doing right now in the country. And so the districts with the same people are doing all 3 of those vaccine campaigns different times of the month, unfortunately, because all of those are existing coherently together here. Screening for disease, diagnosis and treatment, and then of course, patient support. So tracking patients down if they don't return or helping them with adherence. So this is just the sort of picture that I wanted to share for the environment in which we are setting up the emergency and critical care strategy. And it was really important for us to set it up in a horizontal way that really looks at all of the services at the different levels. And of course, as you know, emergency and critical care is beneficial to that as well, because it's really not explaining a specific disease, but it's making sure that we can provide the acute care that's needed no matter what the disease is. So it really lends itself to this transition, and also sort of the focus on how can we reach universal health coverage within Malawi. So I think from here, I'll turn it over to Eneli. And Eneli, you can just tell me when you want me to change the slides. Thank you so much.
So I'll continue from where Emilia stopped from. My focus will be on the strategy and the work that we've done from the policy point of view to clinical care. Yeah, you can.
Can you see it? Eneli, did we lose you?
Yeah, I'm worried we might have lost her audio.
Can you hear
Sorry,
me?
everyone. Oh, now you're back. Yeah.
We can hear you.
Oh, I've been speaking to myself. I don't know where you stopped hearing me from.
Start
From
at the
the
beginning.
start of this. Yeah.
I see. All right. So I was saying that emergency and critical care services are offered to people who are in a life-threatening situation, whereby if much care is not given, they can end into a death or maybe an irreversible outcome. And in our setting, most of the emergencies are aggravated by poverty, unsafe housing, and transport conditions. Here, what I can say is that in our setting, most of the facilities are very far away from the from where people are based. So whenever they have an emergency, for a person to move from the community to go to the facility, so many things can go wrong. And also because of poverty, in some cases, they do not have transport to ferry them to the nearest health facility. So because of this, that's why we decided to look at emergency and critical care as a cross-cutting issue. Because as Amy has lightly put it, whichever patient, whether it's a tuberculosis patient, HIV, malaria, at some point they will still come to the facility as an emergency. So we needed prompt interventions that could help in preventing illness and injury. And also in our setting, most of the emergencies, they come from pregnancy complications, whereby a woman maybe shows up late at a facility. So this emergency and critical care is like cross-cutting, is covering for all the conditions that can present at a health facility. So our goal is to save lives and prevent disability through the provision of state-of-art essential emergency and critical care services that will help Malawi move towards universal health coverage. And we are hoping that we are going to achieve this by making sure that we pull out all the resources that we can, and to making sure that everybody is on the same page, and we are getting all the buy-in from different partners, different players, to make sure that we reach a common goal. And in our setting, we asked ourselves the question, what is essential emergency and critical care, and where is it delivered? So we defined it as the care that should be provided to all critical ill patients of all ages, and whether they are, of all ages in all hospitals in the world. That includes Malawi. And we cannot limit to routine emergency and critical care in just certain areas, because we require a continuum of care with the ability to recognize and quickly respond to an emergency and critical illness. You may wish to know that more than half of the deaths, about 40% of total burden of disease in low resource countries like Malawi, results from conditions that could be treated with pre-hospital and emergency care. And also, we cannot limit just to routine emergency care and critical care, but also we are looking at different levels of care from community, primary, secondary, and tertiary care, with the ability to recognize and quickly respond to emergency and critical care. So this is distinguished by 3 principles: priority to those with most urgent clinical needs, including both early identification and timely care, and provision of life-saving treatments that support and stabilize a failing vital organ, and also focus on effective care of low cost and low complexity interventions. Next slide. So we also look at the burden of disease in need of emergency and critical care services. Globally, burden of disease, like as of 2019, neonatal death disorders were still the highest, with 7.3% of DALEs, and the non-communicable diseases and injuries have increased by 28.2 percent points. And respiratory infections and diarrheal diseases account for 77% of DALEs combined. And what are the causes of death in Malawi? You will see that communicable, maternal, and neonatal and nutritional diseases are one of the highest, and these are seconded by the non-communicable diseases. And in all this, some of these patients will still present in our emergency rooms or in our critical care. So as I was saying, the landscape of the disease, the landscape in our country would say that we also in the same LMIC of more than half of the deaths being about 40%, and 90% of the deaths comes from trauma. I would give you an example. Here in Malawi, we have an M1 road where most accidents happen. But when an accident has happened, for that patient to be referred to the nearest facility, we do not really have efficient ambulance system that can ferry the patient from a scene of the accident to the hospital in time. And even when we reach the hospital, you see that the capacity of the healthcare workers to respond to the patient, in many cases, it was a problem. And also, 95% of global maternal mortality, they are happening in our setting. Like I already explained, that we have a situation where a woman maybe had a maternal complication at a primary health facility. For that woman to be referred to a secondary level, you may have problems with transportation. Maybe we do not have fuel in the ambulance. So that has attributed to most deaths that could have been avoided. And Malawi is estimated to have about 204,568 cases of sepsis as of 2017. Those are our references there. So in the emergency and critical care, our areas of focus are 5. We would like to first look at the first response community health systems. For this one, we are looking at a system whereby we should have in place ambulances that can respond to an accident when it has happened. And we are also focusing on training the communities like along the M1 road to be able to respond when there has been an accident. In some cases, we've had incidences whereby when accident has happened, instead of people trying to support the casualties, they are firstly maybe trying to see what's in their pocket, something like that. But with this focus, we would like to make sure that the community as first responders are sensitized on how best they can attend to a scene of accident. And second of all, we wish to strengthen the transportation system. On this one, we are currently having emergency medical services ambulances placed along the accident hotspots districts, so that whenever there's an accident, they can ably respond to the need. And we are also strengthening the communication system between the EMS ambulance service and the facilities, so that whenever there's an accident or there's an emergency, the response should be rapid. We are also looking at staff. On staff, we are looking at human resource. We do recognize that if we want to effectively deliver emergency and critical care, we need to have adequate human resource. And we are advocating from time to time from our colleagues from the human resource department to support us with more staff. And then we are also looking at space. For a long time, as Emilia has expressed, we have had emergency rooms, but that do not really qualify as emergency, because it was just like maybe a small space where you can welcome the patients, see what the problem is, and then send them to the wards. But in this case, we are looking at a space that we can maybe refurbish, renovate, to make sure that whenever a patient has come, they should be able to get the care in time. The response should be right there and then. And to this, we are already trying to make sure that all the accident-prone districts along the M1, we improve their trauma units, we improve their emergency and critical care. And where there's a need in the tertiary level, we are also looking at making sure that we have in place systems that make sure that we improve not only the outlook, but also the capacity to deliver a service. On the staff, we are looking at the equipment that is needed to support the service. And we do realize that for the secondary hospitals to be able to stabilize patients, to be able to treat patients, they will need a strengthened system that respond to the need. We want to have the staff, the space, and the equipment in place. For the tertiary level, it is our desire to make sure that not every case goes to the tertiary level. In our case, we call them central hospitals. So we want the central hospitals to be able to coach the district hospitals, to be able to make sure that we have put in place standard operating procedures that everybody can follow. We have put in place guidelines that the tertiary level can support the referral hospitals with. Overall, we are also looking at improved governance and leadership. Next slide. So the strategic interventions that we are currently carrying out, we have out of hospital care. On this one, we are looking at community health and family medicine. communication and patient transfer system, like I already explained, and also entry to the facilities. We are looking at a system whereby we don't lose a patient because they came, but we were unable to recognize that this patient needs emergency care, this patient needs critical care. So we are looking at also making sure that at entry point into the facility, we have a good triaging system that we are able to separate patients and we are able to respond to the emergencies. And we are also looking at having short stay units that stabilizes patients before they are referred to the different wards. On the inter-hospital care, we are looking at patient flow. Sometimes patients, because they do not know where to go, we may have a patient, we have an example actually of a patient who died after was successfully referred from one facility to the other, but when they arrived at the central hospital, they couldn't find their way. So it was like, well, how can I go to ward 3A? How can I go to ward 3A? Whilst doing that, we lost a patient, whereby if we had a well-organized patient flow, this patient could have been stabilized in the short stay, and then somebody could have been there to escort them from the emergency unit to the ward that they were supposed to go. And also monitoring and assessment in different wards. We are looking at making sure that we have got a harmonized system of monitoring our patients in the ward and also even the admission. We are also looking at differentiating between the high dependency units, which are ICU level 1, versus the intensive care units that are ICU level 3. We want to be able to say that these patients who needs to be in the general wards and this just in the HDU, and these patients be in the ICU. And for that to happen, we want to make sure that we have got guidelines at all those levels that guides the healthcare provider. And in all this, you will see that we will still need the staff, we will need the space, we need the equipment, and we need a sound system. So just to further show you how we are categorizing the 4 S's, I think I talked much about the staff, the space, the staff, and the system. These have been our main areas of focus. We're looking at the clinical and nursing staff. We're making sure that we empower them with knowledge and skills that they can be able to attend to patients. We're looking at coming up with different policy documents that can support our emergency and critical care document. We are also looking at training the support staff. As I said, that we have had cases whereby a patient doesn't know where to go. We're hoping that support staff can also help us with making sure that the patients are helped in a timely manner. They are directed where they're supposed to go. On supply chain, we're looking at the different medicines, even the essential commodity like oxygen, the availability of oxygen and other drugs that should be available for us to be able to achieve. So we are from time to time advocating for different drugs, different supplies, different equipment that will help us. And on the emergency responders, we're looking at the first line that will respond to emergency on spot. On the space, I think I've also talked about different initiatives that are currently in progress, and then also what we identified to be areas of need. We realized that we needed to have a sound emergency accident and emergency department. We needed to have high dependency units. We needed to have intensive care units as well as isolation rooms. On the staff, we need emergency vehicles to be able to ferry these the women, the children, adults who needs referral from one place to another. We need medications and consumables, and we also need monitoring equipment so that we should be able to identify an emergency when it has happened and intervene quickly. On the systems, as I said, community are currently our primary first response because they are there when maybe an accident has happened. They are there when a person falls sick, they just collapse, they need to take that person to the hospital. We need emergency transport, we need admission, referral, and transfer. And also we need different levels of medical care. So at this point, I'll hand it over back to Emilia to continue with the implementation of the policy.
Great, thank you, Eneli. Hold on just 1 second. I have to, sorry, it's not going to, my video is not going to get better than this because there just isn't electricity at the moment. So I'm just going to turn off my video so that it's not this way. All right, so over the last 9 months, we have been implementing and working on prioritization of activities for the strategy. And Eneli has been spearheading a lot of those efforts along with Norman and his team from the Emergency and Disaster Relief Unit. So I'll just go through a few of them and try to leave some time for questions as well, because we'd love to hear others' experiences and ideas. But over the past few months, what we've been really trying to do to make sure that we can coordinate efforts and ensure that there's prioritization of the activities that either need to come first or that really need to happen in a speedy manner is that we prioritize, since it's a 10-year plan, we prioritized a 2-year plan and taking out the activities in that way. And that was done through a consultative workshop and evidence-based from where we had evidence within Malawi or in similar contexts. And then we're utilizing this to one, cost it so that we can advocate for funding and to also bring people together. So an example recently is that the World Bank and the WHO have had money that they've wanted to put into emergency and critical care services, especially around the sustainability of those services with COVID and other emerging pandemics. And so when they came to the department and to Norman and Eneli, they said, listen, here is our prioritized plan. What can we do off of this list? And so it's really helpful also to make sure that we're checking off the things that the team wants to do and that are prioritized through this way. We're also making sure that we're coordinating with other departments. Unfortunately, in Malawi, sometimes there's guidelines or protocols that can be overlapping and perhaps don't say the same thing. So for example, the capital investment plan is large pieces of equipment or infrastructure that needs to be built. And so making sure that everything that's in this prioritized plan is in the capital investment plan so that if, again, a funder comes and is interested in critical care, they can be referred through the capital investment plan over to the emergency and critical care team. And this also goes for several other systems, as you can see, including human resources, the maintained COVID response, all of the consumables, equipment, drugs, and also any of the clinical guidelines and digital health systems. So to make sure that if there's a digital health system that is being built, that it includes emergency and critical care, or vice versa, if we get money for it from emergency and critical care, that we make sure that it expands to, the hospital inpatient space or in an outside hospital communication way. A big piece of the implementation is making sure that people know about it. And so, and how can we advocate through, additional funding and making sure that there's sort of buy-in to the policy. And so a big piece of that over the past few months especially is making sure that There's outreach to the government in sort of the top political levels in parliament, other ministries that have quite a bit of stake in the policy, such as finance, local government, obviously some in sort of the Ministry of Gender and Social Welfare as well. Of course, implementing partners and donors, but also the local Ministry of Health and sort of implementers on the ground at the district level. And then of course, the non-state actors, civil society, religious, cultural leaders as well. Following that dissemination, we've also been working on strategic media engagement to make sure that the communities know and are engaged with implementation, because of course it's different in different districts for geography, the amount of staff that they have, the amount of hospitals or facilities. And so it really requires that contextualization on a district level, which leads to the third one of implementer engagement. What we really are critically focused on as well is making sure that with the prioritized implementation, that there's coordinated and really systematic processes that are put in place. So right now, Eneli is working on bringing together, oxygen manuals, both from the part of like biomedical engineering, but also the clinical part, and how do we make sure that those come together and that roles are very well defined and that there's not overlap. How do we make sure that standard operating procedures for oxygen, for ambulances, et cetera, are also coordinated between different teams so that everyone has the jobs that they're doing and that we can clearly provide care in a high quality way and at the same time maintain those systems. But of course, it's really that documentation of care practices, the making sure that the data is there in the implementation so that we can track the performance and so that we know exactly where we're failing, and either it's not working in the way it's being implemented and so we need to change it, or there's some other input, and really making sure that we know where those deficiencies are, but also what's working well so that we can reiterate on the strategy and build out stronger ones in the future. So I think a lot of what I just mentioned is on this slide, but I think also it's not just the monitoring piece, but also how do we integrate it into this continuum of care from primary to secondary, and making sure that if a patient is found in a critical condition in the community, that they're transferred to the hospital, received quickly at the hospital and given care, and then decisions are made for diagnosis or further care, and making sure that those systems can talk to each other. I think a big aspect of this too is making sure that through the monitoring and the quality that we can increase patient trust in the system, and so that people want to access health services and want to get the care that's provided. And then of course, sort of matching that to the implementation and ensuring that we can have continuous quality improvement. So that's the end of our presentation today. I hope that it was interesting, and just in terms of matching that clinical lens to the actual implementation of a program, to then the policy and sort of strategic objectives that are created from what happens on the ground and moving back through that cycle. I know for me as a clinician, and I think Eneli would say the same thing because we've talked about it several times, but I think it's really powerful to be able to bring the view of like that on the ground experience as a clinician, but then also understand where we need to maximize the public health in a way where we're prioritizing correctly, but also measuring it so that we can create the best care system that we can. So I think we would both welcome questions, discussion points, similar interests. Our emails are here as well. If we run out of time, if you have any questions or any follow-up that you'd like, and thank you again so much for having us.
Thank you both so much. Oh, go ahead, Sohail.
I was going to say the same thing. It's okay. Thank you, Emmy and Eneli. Really appreciate the insights and the work. It seems very exciting how it's progressing forward. Thanks, Tiffany, for putting in the evaluations in the chat. We encourage everyone to fill it out. But we do have time for questions, so the floor is open. And feel free to raise your hand. I'm happy to kick things off with one question, probably for Eneli. I was intrigued by the community response piece that you were mentioning, and just wondering if you can elaborate a little bit more on what that entails. Is that educating the community through some of the public campaigns on who to contact or how to provide response? Or can you just describe that a little bit more?
Thank you. So communities as first responders, in our setting, we do know that whenever an accident has happened, mostly the community, the people surrounding are the ones that are going to come. So sometimes they'll take the patient, maybe call for just the nearest vehicle available, put the patient in the car to go to the nearest facility. So our main focus is to make sure that we educate them on how best they can respond. How can they handle when such cases arise? Because maybe some, like the basic principles like stabilize the head, make sure you immobilize the head, make sure maybe you stop the bleeding, so that whenever the patient is going, at least you know that you have taken care of the airway, the breathing pattern and the circulation. And also to teach them of the, like, so to say, like a civic education, so to say, as in how best can they like handle the patients. As I was saying, some will start searching in the pockets because now this person is not responding and you want to see what they have. They have money, they have phones. By the time you are doing all that, we are losing the patient. So we're trying to bring like that sense of responsibility so that whenever an accident has happened, they should look at it as um, a situation of wanting to help, not to get something out of it. And also they should be able like to refer the patient as soon as possible. And to this effect, we even had recently the Secretary for Health releasing a circular to say that whenever patients have come, maybe accident patients, you don't have to rush them to the police, because previously that was the case. You have to get a police report first, then they go to the facility. In that way, we are losing the person. So we've been able to do, I mean, that's the idea, to be able to make sure that they respond, the patient goes to the facility as soon as possible.
Thank you. Appreciate that. Sorry.
I wanted to share, I think there's been some really, I mean, this is obviously a topic very near and dear to my heart with critical care and emergency response. And I just want to share a couple links in the chat because it overlaps so much with the work that you're doing. So one thing is the Stop the Bleed program, which is in India, which has all of similar components to what you're saying. And so this is actually a kind of a train bystanders specifically to have a trauma response in rural India and along major highways that people use, so where most accidents happen. And they actually use drones to deliver emergency supplies. And the other one, which because it came up earlier with our colleagues in Uganda, is organizations actually purchasing boda bodas and turning them into ambulances for exactly the reason that you mentioned. It's usually the community and bystanders who have the sources of transportation. So how can we leverage what exists already to get people to the medical care that they need faster? So yeah, I really love the work that you guys are doing, and thank you so much.
Yeah, and just to add that we also have the bicycle ambulances, like for community referrals. We invented a bicycle ambulance, I think, where whether a pregnant woman in need of emergency care, even a patient, they put them in that bicycle ambulance and then go to the nearest health facility just to respond to the need.
And I would just add on while we're waiting for any more questions, but I think that this work, sort of to what you're saying, Teresa, too, has been just such a wonderful experience to be able to reach out to different programs in different countries who are doing similar work. I know, Eneli, you were just using some ideas around indicators. I forget from which country, but from another country, especially around oxygen. And we were sharing some of the work and ideas with Lesotho, who is actually developing their own emergency and critical care survey now. And Norman was able to give them a lecture and sort of workshop around how it was developed. So I think also just that knowledge sharing in different programs and how we can all come together has been a really important part.
Yeah, Emilia, that would be Bangladesh. They are one of the first countries to make sure that they develop oxygen indicators. And from them, we have also learned ourselves in Malawi to start looking at the indicators, and we have just recently developed some.
I'm curious, I guess, from both of your perspectives, when you're working on a project so big with so many people involved and so many different agencies and entities involved, sometimes you can agree on the vision, but disagree on how to get there, right? And on the nuances of the mission. And when that happens, sometimes things can collapse. So has that happened in your experiences so far, and how have you overcome them? Or can you describe any challenges along your path?
I'm going to let you come in first, Eneli.
Okay, so I would say that to avoid such occurrences, firstly, we had to make sure that we have the prioritized implementation plan that Emilia talked about, the 2-year implementation plan. And also in the clinical directorate, we have a division that I'm working in, the emergency medical division, whereby all the work around emergency, the partner cannot implement without us having the knowledge of what they would like to do. This is just to make sure that we harmonize the implementation, and where it is necessary, we make sure that sometimes even an activity can be funded by 3 or 4 different partners. But also we have emergency task force, and we have an Excel sheet that is online, like I think in Google Drive, whereby everybody who is implementing something on emergency and critical care and oxygen, they have to update. We have to update constantly, just to make sure that we don't duplicate the efforts. We know I think we've learned the hard way that sometimes you just hear that a certain partner is doing this, which is contrary to what you planned in the beginning. But the ability to have everybody who is having similar interests and making sure that the working group is active has helped us to make sure that we keep our progress on track. Emilia, you can come in if you have additions.
No, that was very well said. And I think one silver lining of the COVID pandemic is that it did bring a lot of people together in a coordinated way. And so I think some of these initiatives that Eneli was mentioning were able to sort of come out from there, and everyone was super focused on oxygen. And so we're kind of trying to take that focus and move it into, a full package, emergency and critical care response, so that we can make sure that we're the most efficient with oxygen and provide it to the patients that need it, but in that sort of full continuum of care piece for the emergency and critical care. So I think trying to keep that up now as we move forward with other things that have come up. As I mentioned before, Malawi has gone through a polio case this year that was wild type, and so need for massive vaccination campaigns for everyone under 15. And then also we've been hit really hard with cholera after two pretty nasty tropical storms in February and March, which also left their own damage. So I think it's just a matter of how do you make sure that that type of response as well can be linked to more of a health system strengthening approach that hopefully can continue to build even after COVID has decreased.
And also just to add that we've made it clear that government is the implementer. Everything that each donor, each partner is doing is just supporting the efforts of the government to implement their service. So by the end of the day, even if we have so much support from different partners, the bottom line is they are doing all this on behalf of the government. So whenever they wish to do something, to implement something, it needs to go through the health working technical group. It has to be endorsed, and then they move forward. In that way, we at least have some coordination, and we are able to run things.
All sound like very important lessons. Very much appreciate you sharing the insights both into the content and the process, and making sure it's done in a way that is sustainable and as you both said, really strengthens the health system in the long run. Any other questions from the group? Okay, well, with that, then thank you again so much, Emilia and Eneli. I really appreciate your time. To the audience, please take a moment to fill out the evaluation if you can.